But here to help us understand maybe when not to use MIS for deformity is Jay Turner from the Barrow.
All right, thank you, Coy. Not the first time people confused me and Praveen. This is a topic that's of a lot of interest to me. This is an obvious application for MIS. Open deformity, while effective, has significantly high risk of complication, high blood loss, and the tissue-sparing approaches with MIS are well suited for this application. However, MIS also has significant limitations. It's a bit of a paradox in treating adult deformity. Adult deformity, by nature of realignment, you need tissue release, and MIS it uses minimally invasive corridors with small incisions, and getting those corrections can be very challenging, especially in rigid adult patients. Nima touched on this, but there's often prolonged operative time, multiple stages, multiple days on some occasions, and prolonged anesthesia. And so, we do need to be selective when considering MIS, everybody has a bit of a different algorithm. Some have tried to combine open posterior incision with minimally invasive anterior in order to increase the corrective potential, and while that is effective, you lose essentially those benefits of MIS by having an open posterior incision. So that's not what we're talking about here. We're not talking about hybrid, we're talking about circumferential MIS, so MIS from the front and percutaneous from the back. We've seen this a couple times already this morning. I think that the take-home message from this algorithm, which provides some guidance on who we should and should not be doing this on, is that the patients that are favorable are ones that are flexible, the mild to moderate deformities, and short segment corrections, and the ones you need to be cautious. Doesn't mean you can't do them, but you have to be thoughtful and cautious, are the converse, the rigid deformities, severe deformities, and long segment corrections. And I think in deformity in general, our goals have to be the same and aligned, whether you're an open guy, an MIS guy, or somebody who does both. And really the goals are symptomatic improvement, achieve your realignment goals, whatever those may be, and that this is a durable treatment. Doing a small, minimally invasive surgery that has to go back in 3 months because you have an adjacent segment issue, you didn't do anybody any favors. And so the durability, I think, is of critical importance. Another consideration, as we're thinking about open and MIS approaches, is what's your strategy? We often think for open deformity of treating the full deformity. There are occasions, especially for older patients, where we're doing more selective approaches to deformity, and this comes into play, especially for MIS, where you're treating fractional curve or apical, the apex that's more symptomatic. And so I'm just going to run through, before getting to the ones where I think are more challenging, some good candidates. We've seen some. Praveen showed some nice cases. I like MIS for mild to moderate degenerative scoliosis without a lot of coronal malalignment. So here's a patient with a mild scoliotic curve, good sagittal plane, a healthy 5-1 disc. And this is, I think, well suited for a lateral approach on the concave side. You can achieve that from a single incision, access all 3 of those disc spaces with really a minimal footprint, and then lock it in from the back. And this is, in my mind, just as much a degenerative surgery than it is a deformity surgery. Similar patients, this one with a prior laminectomy, a little bit more of a significant scoliotic curve, 37 degrees. A little bit of sagittal plane abnormality, but also not bad. Again, a good 5-1 disc, and this is when we're really treating the symptomatic levels with 3-level lateral and perc screws. So I like it for this application. I also like it for adjacent segment disease and revision, but specifically when the deformity is in the mobile segments. I think that's a really important concept. So here's a patient that had a prior 3-to-1 and over 2 separate surgeries, and presented with the sagittal plane deformity. And if you look, it's really proximal to the prior construct, reasonable alignment from 3-to-1, from 4-to-1, and really just a kind of a rigid kyphosis, though mobile segments above the construct. And so this is one I thought was well suited for a circumferential, minimally invasive approach with a lateral approach initially. This was one that was rigid intraoperatively and opted to cut the ligament and put some hyperlordotic cages in, not to get hyperlordotic correction here, but really just to neutralize those levels, and then locked it in from the back with percutaneous fixation and a small posterior column osteotomy at the bottom, and got a reasonable realignment and kind of restoration of more physiological alignment across those segments. And this is a similar concept in the coronal plane, so that this is a patient with a prior 4-to-1, and you can see actually a good coronal alignment along the length of the construct, and the deformity really proximal to that deformity. We see two mobile segments there, pitching the patient over to the left. This is someone that you can do similarly, realign with MIS techniques, laterals and perc screws. And just to kind of draw some contrast, this is a very similar appearing deformity that needs a very different solution. So this deformity is within the construct itself, similar coronal malalignment, but the deformity is actually locked into those fixed segments, and this requires a revision of that construct and a 3-column osteotomy in order to address the alignment in the coronal and sagittal plane. So where circumferential MIS struggles is situations like those, fixed deformity, particularly these iatrogenic deformities, we have to revise the construct. It struggles with coronal malalignment in some circumstances. This is a paper that Corey Walker and Jake Godzik put together from our experience at BNI, looking at CMIS for patients with coronal deformities, and really subdividing it into looking at the three main BAU categories, A, B, and C, and where we do well and where we do less well. And we see from this figure here, we did not do as well with the type Cs, with the mean still malaligned for those type Cs, where we're not getting them back to a good coronal global balance. And this is kind of a example of a patient with a type C, just to illustrate the concept. You see the patient's pitched over toward the convexity of that primary lumbar curve. The L4 is very angulated there. If you correct that primary lumbar curve without addressing the fractional curve, you're going to actually make that deformity much worse and pitch them further off to that side. So for this patient, you really need to correct that fractional curve. In this situation, you see a very rigid fractional curve from 4-to-1 there with bony overgrowth. For me, this is one that's very difficult to address, minimally invasive. This is one I need to open up. And so I spend time on that fractional curve to really horizontalize that L4 end plate. And I did this with some asymmetric T-lifts on that side to make sure we maintain a good, restore a good coronal alignment. There's the pre to post-op. And finally, long segment reconstruction. You can see that in Praveen's MISDEF2 algorithm. Long segment reconstruction needs to be carefully weighted for this. Here's another case example. This is a 72-year-old with this significant coronal and sagittal plane deformity. If you look at the deformity, look at the CT, it's really driven by this focal scoliosis and kyphosis at L1-2, but with a severe coronal and global malalignment. And this is one that I want a UIV in the upper thoracic spine, and going to upper thoracic spine in my practice, given all the inefficiencies with MIS, is one I don't do MIS. And just conceptually, Nima touched on this a bit. I think we can all agree this is 3-level fusion, percutaneous is MIS. How about this? There's a T10 pelvis with 20 incisions. Is that still MIS? How about this? Midline incision, perc fascial, is that MIS? I mean, it is by definition, but where are diminishing returns? And so, for me, if I'm going into the thoracic spine, especially upper thoracic spine, I find the added benefit and the value there is decreased with minimally invasive. I'm going open. And so for me, this is an open posterior approach. This is what we did. We just focused on that L1-2 level, which really, all the correction came from. And that was our final realignment there. And so to summarize, MIS approaches for adult deformity are attractive and can certainly be effective. It should be used cautiously. I think there's wisdom in that MISDEF2 algorithm, even though it's not data-driven. It's based on a lot of experience. And these are the scenarios where you should be cautious to use MIS. And independently, the goal has to be durable improvement in symptoms and durable realignment, regardless of which techniques you use. Thank you for your attention.